Greetings, students. Welcome to this recording of how to complete a second read of a journal article. The article that we're going to do a second read of is one that you are particularly familiar with because it is the same article that you did a first read for. Remember, the purpose of a second read is to specifically identify the strengths and the weaknesses of the methodological approach that the research study and its respective authors chose to select. As a guidance, I have created guidance documents pertaining to each study design. Those documents are going to be useful for you as you engage and try to identify strengths and weaknesses of the studies that you will cover in your journal critique assignments. And so, before I proceed, I would like you to pause the recording and bring up the guidance document for a cohort study because this is what the study design was for this particular journal article. In addition to this, I anticipate that you have internalized all the different types of selection bias as well as information bias based on the document that I gave you. Why did I suggest you do that? I suggested that you do that so that when you're reading the methods section line by line, you can be able to point out and highlight the different sources of bias because you will already been familiar with them. So, let's get started. At this point, I would like you to scroll to the methods section of this particular journal article and read it line by line all the way until the end of the paper, specifically the end of the methods section. While doing this, I want you to take a highlighter or pen and underline or highlight sections that identify potential strengths or weaknesses just based on an initial cursory review. Once we're done with that part, then we'll move on to the guidance document, where we'll read the 13 or 14 or so questions depending on the study design that you have. And we're going to look at each question to identify additional issues related to strengths and weaknesses of this research study. From the totality of that process, we're going to identify 5 main issues that we would like to address in a journal critique if this were a written assignment. So, at this moment, I would request you to pause the recording and proceed with underlining sections in the methods section as you read line by line on areas that would be pointed out as strengths or weaknesses. Welcome back. Hopefully now you have gone through the process of highlighting areas that you believe are strengths and weaknesses, keeping in mind the framework of the different types of bias that you have already learned in class. So let's get started. As we start the methods section, I underline the study design. And why is this important? Underlining the study design is important because the study design by nature provides you with either specific strengths or specific weaknesses per the document that I gave you. And so we know that retrospective observational cohort studies are prone to potential abstraction bias, basically bias when data was being abstracted from the study. So that is already a point that you anticipate to bring up if you want to critique the study. Also, because it's a retrospective cohort study, you know that one of the main advantages that this study provides from a methodological standpoint is it can allow you to show a causal relationship between your exposures and outcomes. Okay, so underlining the study design is important because just by looking at that alone, you can identify strengths and weaknesses. The next part that I have underlined, and let me just check this so that we know that we have covered that. I underlined in Taiwan. And in Taiwan is underlined specifically because that affects what? Issues of generalizability of your study. How generalizable is your study to other populations? Because this study was done in Taiwan and specifically only done in a single site, the National Cheng Kung University, then we can point out that this is a weakness in the study, because we're not able to generalize its findings to other populations. They may not be reflective of those from this center, as well as those populations who are outside of Taiwan. So here we have a third area that I have highlighted. Patients admitted to ICU during the transition phase were excluded from comparison because bed numbers were not consistent and the nurse practitioners were still in training. Again, I started this presentation without reminding you what the research question was because I anticipate that you remembered what the research question was, but just to be reflective, our research question was, what is the effect of addition of nurse practitioners to surgical ICUs on the outcomes of what? Let's look at the main outcomes on the outcome of mortality, okay? And specifically ICU mortality, okay? So looking at this point, okay, during the transition phase, 2013, there was a mix of effects of the exposure because the nurses were still in training, and so we can't really say that all nurses were fully trained to affect the outcome. So in all fairness, removing 2013 is actually a good thing in the study because this gives the study a stronger look at the effect of the exposure on the outcome. Adding the year 2013 would actually muddy the effect of the exposure on the outcome because in 2013, you had a mixed bag of persons who were trained. You had some nurses who were trained but were still in practice, and so that may actually affect the accuracy of the results with regards to affecting the outcome of mortality. And so this is an issue that is important to bring up as a strength in the study. Moving on, if the ICU admission is requested before a scheduled surgical procedure by the surgeon or anesthesiologist during preoperative assessment, the admission is classified as a scheduled admission. Why did I underline that section? One of the things you realize in the article, specifically when we review the results, is that the results were provided to us based on whether the admissions were scheduled or whether they were unscheduled. So they looked at the results of the study, looking at scheduled admissions, how was the effect of nurse practitioners on mortality, as well as unscheduled admissions. So here we are being provided with how they classified or defined a scheduled admission. And that's important, right? That's important to make sure that we classify scheduled admissions and classify unscheduled admissions accordingly. Based on this definition, I think this is a pretty good definition of a scheduled admission. And so we can say that the attempt to do this also reduced misclassification bias. And so we can say that this is a good thing that they operated with a solid definition of what they classified as a scheduled admission to make sure that it was fitting with this definition, and that would be considered something that is a strength in the study. So again, when classifying something as a strength or weakness, look at how would this have affected the results. What if they misclassified what would be a scheduled admission and what would be an unscheduled admission? Or what if they didn't have a definition that was very distinct? In other words, it was a little muddy between how someone would define a scheduled versus unscheduled result. You would see that the results they gave by these subcategories of admissions would have been inaccurate. And so in giving us a good definition, we are sure that they consistently apply this definition and that would not affect the subgroup results that they provided at the end of the study. And then the methods continues to provide us more definition of how they did the training, and also provided some context of how training was done in Taiwan, which is all good information. Okay. They also provided information about the number of beds, etc. But as in my highlighting, I didn't see anything specifically that pointed to methodological issues that could be addressed. Okay. Okay. Moving on to the study population section. Here I highlighted the last portion of this statement. Because bed numbers was not consistent and the nurse practitioners were still learning in the transition phase, data from the patients admitted to ICU during the transition phase were excluded from the outcome analysis. This is in alignment with the same point that was raised earlier about them excluding data from the transition period. And so the same advantage is just being reflected here in the study population section. Next, data associated with clinical care, such as vital signs, cardiac rhythms, lab results, central venous pressure, intravenous fluid content amount, urine output, parameters of mechanical ventilation, are all entered prospectively into this clinical information system by nurses, doctors, nurse practitioners, clinical pharmacists, nutritionists, or respiratory therapists. Clinical data during the ICU stay were collected retrospectively from the clinical information system, and demographic data were retrieved from the hospital admissions database, hospital administrative database. So here we can point out to two things. Like I said earlier, by design, you can always point out to issues related to data abstraction, because that is built into the design of retrospective cohort studies. There's always a problem in terms of abstracting records. So there's always a potential of human error in terms of entering the results here, or maybe in lack of entry of information. So you can always point that as a potential weakness, because we all know the nature of administrative databases. Also, in looking at the next point highlighted, severity of illness is routinely assessed within the first 24 hours of admission and before discharge during the acute physiology and chronic health evaluation score, aka the Apache score. And the Apache score here was used to basically classify patients based on how severe their illness was. Why is that important? So you can either classify severity of illness based on, let's ask the practitioners who are seeing them, how severe do they feel their level of illness was? That would be somewhat subjective. The Apache score is an objective measure of the severity of illness. It actually requires you to put in a number of comorbidities that the patient has, and a number of other things before a score actually pops up. So you can read more about the Apache score, but the point I'm trying to make here is that the variable severity of illness was actually classified well, because they use a score. And remember when we talked about the advantages of using a validated score to classify something earlier, in that this is a positive thing that can be pointed out in the study. This is a strength in the study because they were trying to avoid what type of bias? Misclassification bias. In other words, in classifying individuals based on the severity of illness, we are sure that the level of severity of illness was classified appropriately because they used a validated score and not a subjective measure. So this was an objective measure to determine severity of illness rather than a subjective measure, which is a strength in the study. Next, comorbidities were identified according to the diagnostic codes of the respective hospitalization and the corresponding international classification of diseases. So in this case, ICD-9 codes were used to enter diagnostic codes, and this is always an advantage because ICD-9 codes is really an international language to a certain extent of coding diseases, and so we're almost sure when we capture someone a diagnosis code of 400 that's related to hypertension, we're sure that that person had hypertension because that's a universal code that's used. And so this is a positive thing because we're sure that whatever diagnoses were captured in the study, that those diagnoses were classified appropriately because of this, the use of ICD-9 codes, and that also reduces misclassification bias. And then we scroll down to the statistical analysis section. We see here, and I'm going to just read the sections that are appropriate. Logistic regression using general linear models and stepwise regression with backward elimination were used to investigate independent predictors of ICU mortality. Now, you may not know what this entire statement means, but I know you've encountered this term, logistic regression. Remember, we talked about the advantages of using regression techniques, whereby these techniques allow for adjustment of confounders in a research study. So when you're looking at a particular effect of a research question, of the particular effect of an exposure on an outcome as per a research question, regression models allow you to investigate several predictors, specifically if it's a multivariate analysis. Multi meaning multiple variables were entered into the model. And so this strength, and we can highlight all of this, this is considered to be a strength in the study. These two issues are really the same. This is a strength in the study because you are now not only just looking at solely the effect of nurse practitioners in interventions inside the surgical ICU or their input in the ICU on mortality, but you're looking at the adjusted effect. So how are we adjusting for the effect of other factors outside of nurse practitioner influence? So it actually tells you when you look at the results what was adjusted for, and those are the variables that the model was able to adjust for in the analysis. What I'm expecting you to do, again, because I know that you haven't done statistical analysis or biostatistics as a course, is this: when you see multivariate regression or just the term regression, you look for multivariate or multivariable. That just tells you that they did an analytical technique that allowed for the adjustment of confounding factors, and that's a strength in the study because it helps to reduce bias due to confounding. And that's really the expectation I have, okay? And so that was it with regards to looking at the method section line by line to identify strengths and weaknesses of the study design. It is also not, it is also at this point where now you can begin to formulate of these issues that I've raised, which are strengths, which are weaknesses, okay? So you can now begin to point out this one, there's a strength here and also a negative here. Here in Taiwan is definitely a negative. This was definitely a positive, okay? This is definitely a positive issue. Okay, this was a positive issue, but it is also something that was already talked about earlier. So this just reinforces the point earlier here that the records during the transition phase were not included. Okay. This is a this cuts two ways. You can talk about just the potential for data abstraction, in bias during abstraction of data, in terms of removal of the data from the database. You can always talk about potential for human error when entering data into a particular system. So you can address it as a negative in one of two ways. Severity of illness and the classification of the Apache score, this was definitely a positive thing. And the comorbidities and their classification, this is a positive thing. So thus far, you're seeing, a number of positives and a few negatives, but they're far more positives than negatives. And so we can begin to formulate somewhat of a picture about, well, how was this study designed? And really, are we leaning towards a recommendation of strong, fair, or poor? But we're not done yet. The next step now would be for you to pick up your guidance document to make sure that there's nothing else that you have missed from this study with regards to critiquing. And so now at this moment, I would request that you pause the recording and turn to the cohort study guidance document. So now here's the critique guidance document for us to again make sure that we have done our due diligence and have identified all the strengths and weaknesses in the study. And so we're going to go through point by point to identify any additional strengths and weaknesses that we didn't highlight in the first initial round of review. First question asks, were fewer than 50% of eligible persons were there fewer than 50% of eligible persons who participated in the study? And if they were, then there's a concern that the study population does not adequately represent the target population. So let's go to the document and see. Usually for most well-written papers, there's a figure that identifies the flow of participants to the study. And so they started off with 1,755 consecutive admissions. These numbers were excluded because they didn't meet the inclusion criteria, leaving this number of eligible admissions. And so how you identify whether 50% or more who are eligible did not participate in the study, you look at make sure that these totals here add up to the 8747, and they do. So meaning of all eligible admissions that fitted the criteria, all of them were included, and therefore this is a positive thing. Okay. So going back to our document, we can say we answer this as yes, and therefore that reduces the potential for selection bias because all of those that were eligible were included. And so here we've identified one positive thing related to item 1. And you can say, on the sheet of paper that you're going to use to do this process, you can say that this is a strength. Okay. Again, this is just for your own notation. Doesn't mean that you're going to submit this. Please, this just means that you're noting to yourself that you have an additional issue to present as a strength in the study. Next question. Were the inclusion and exclusion criteria developed prior to the recruitment or selection of the study? Were the same underlying criteria used for all the subjects involved? And so usually this the second half of this statement is what is applicable to retrospective cohort studies. Remember, when I developed this document applies to both retrospective and prospective cohort studies. You just have to frame your mind around how the particular point applies to which version of the cohort study design. So in this case, with a retrospective cohort study, the inclusion and exclusion criteria, we just want to make sure that they were consistently used, okay? And in this case, they were consistently used. And let's just remind ourselves what were the inclusion criteria from the method section. And this is usually under the study population section. So essentially, they said all patients admitted to the surgical ICU during the 5-year period were eligible for inclusion in the study. For multiple ICU admissions during the same hospitalization, all ICU admissions were included. And then they only excluded those from 2013. So that was the inclusion criteria, and it was applied consistently, and so we can say that this is a positive thing. Now, what if this were the opposite, right? Let's say they didn't include consistent inclusion criteria. Let's say for a certain year they decided to include only patients who had a length of stay that was over 50 days. So this is sort of an extreme example, but let's say midway they used different criteria for different records that were included in the study. In that case, you can point out to potential extraneous factors that could then affect the results of the study. So one could say, in that particular year, only including patients who had a longer length of stay may have affected the outcome of mortality. Okay, so that usually should not happen, where the inclusion criteria or exclusion criteria are changed for the study. Every record, in this case for a retrospective cohort study, or every person who's included in a prospective study should have been assessed based on the same inclusion and exclusion criteria. And if there are differences, then that could either have the potential for selection bias or confounding bias depending on the circumstance. And you would just have to justify which of those two types of bias do you believe has happened. In other words, if widening the criteria or narrowing the criteria included confounding factors that could have affected the result, then you can talk about confounding, bias due to confounding. And you could also address the issue of selection bias, where now you're selecting in people who may not be reflective of the target population. You could argue and present your case in either of these situations. As long as you justified correctly, I will give you points. So in this case, this is a strength. The criteria were applied consistently. And like I said, when you're explaining this paragraph, you should expand upon the fact that they addressed all records following the same inclusion criteria, and therefore that minimizes the potential for confounding bias. You can even say, for example, the fact that they made sure that they all consistently excluded records from 2013. This would mean that they're trying to make sure that we're making sure we're including only those records where nurse practitioners were fully trained. So you provide an explanation so that I can see your thought process and how you're thinking about these issues, because ultimately that's what's important and that's what's going to help you on your comprehensive exam. Next question, was a sample size calculation done? So I said if this is done, that this is a good thing, okay? At the same time, we have a threshold for how low is too low. So it is not a requirement to do a sample size calculation for cohort studies. It is great if it does one, right? It is great if it does one. And some do and some don't. So if it's done, it's a positive thing. If it's not done, you could point out to be a negative, especially if some of the results don't turn out to be statistically significant. For example, in our study, the effect of nurse practitioner addition was only found for those admissions that were, let's go back and let me just point out to the results so that we can remind ourselves. Okay. So the effect was for scheduled admissions only, remember? But for unscheduled admissions, there was no difference. And so if a sample size calculation wasn't done, someone could always point out to, well, maybe if you had enough sample size, you may have been you may have had enough of records to be able to show a statistical difference. So relating to this point, let's find out if it was actually done. Okay, first. So, and how would we know that? We would go to the method section and see, or you could just do Control F and search for sample size. That's another quick way I do that. So it's not there, but you also make sure and go back and see if there was a sample size calculation done. And as you recall, we didn't see any notation about a sample size calculation being done. And so you can point that out as a weakness. No formal sample size calculation was done. Okay. And I also added how low is too low. There's sometimes when you can definitely say that you didn't have enough to conduct your study well. Any study where you have only recruited less than 30 participants, that is a study that doesn't have enough sample size to find any result. Okay, so if you find that is something where you can always say that the sample size was too small. That's a definite place where you could say sample size was too small. Anything under 30, that's a weakness that you can definitely exploit and say the sample size was too small. But on the flip side, more is better. Over 30 is better, but over 30 doesn't necessarily mean that you had enough sample to reach a statistically significant result, which is the reason why people do sample size calculations. Okay, more is better. Over 30 is definitely a good thing, but for your study to be even more legitimate or even more valid, doing a sample size calculation beforehand to make sure that you have enough people to do your study is the better option to go with. Okay. Was exposure determined before the outcome? And this was done, right? Because they looked at mortality at the end, and so this is something that was definitely done, and this is a strength. And seems obvious, okay? But you just have to make sure that that was done in the particular study. Okay, so this is a strength, this is a weakness. Okay. All right. Was there too much dropout? Now, the point here is that dropout usually is, let me read the narrative so we can be on the same page. Too much dropout in cohort studies, sorry for the typo, in cohort studies is considered a problem. An overall follow-up rate of at least 80% is considered acceptable. Okay. The concept of dropout may not be directly applicable to retrospective cohort studies because that's the study design we have. However, dropout usually manifests itself in the form of missing data, and I'll discuss this in item 12. So the point about dropout is more applicable to prospective studies because that's when people drop out of studies physically because you're recruiting live human beings. And whenever dropout happens at a threshold that's more than 20%, as I said, some studies argue more than 30%, you can use either. As I said, there's no document that says this is definite. Some use 30% dropout as bad. Some use 20%. Whatever you pick, just able to follow up and justify in your write-up, and then tell me that this is potential for selection bias, specifically loss to follow bias, if this happens. Now, this is not applicable to the study we're reviewing now, okay? But we're going to address this in the form of missing data through item 12, which we will cover in a few minutes. Sufficient time frame to see an effect, okay? So this point addresses the fact that one must make an educated assessment on was there enough time to see your outcome of interest. For instance, I state that it would be unrealistic to see a cardiovascular event from someone who has had no risk at all over the course of a study that you say, I want to only do this study for 3 months. If you're really going to do a study on people who have no risk for cardiovascular disease, if you're expecting to see cardiovascular risk or cardiovascular outcomes in 3 months, then you're not allowing for sufficient time for the outcomes to occur. Because in real time, for someone who's relatively healthy, it can take 10 to 20 years for cardiovascular disease to actually manifest itself naturally. And so that's not enough time. In this study, this was a 4-year study, and during the course of this time they were looking at ICU mortality as an outcome among individuals who are actually sick, and so this is not unreasonable that they had enough time. So they did have enough time to see the outcome, and that's considered to be a strength in this study. Okay, so if they want to look at ICU mortality within even a year's time frame, that's also reasonable. So looking at this point, our study has met this criteria. Different levels of the exposure of interest. That's not really applicable to our study, but this point really brings up if you have an exposure of interest such as drug exposure, right? You may want to look at high dose versus low dose versus medium dose, and looking at that allows you to definitely look at the true effect of the exposure on the outcome as you up dose, as you increase the dose, and if you as you lower the dose. If this is done in a study, this is a positive thing. Not applicable in our study because our exposure of interest was just nurse practitioners. Number 8, if the outcomes and exposures are not assessed in a methodological sound way, then that can introduce problems. This issue addresses where the outcomes and exposures assessed in a methodologically sound way. And if you recall, this is a point we already brought up in the initial round of review. We said that they use the Apache score to assess covariates. So this point not only just applies to outcome measure and exposure measures, it also includes covariates as well. Looking at the outcome itself, ICU mortality, how was that captured? That was likely captured from the records. Is this a good way of assessing mortality? Absolutely. So you can point these as these were definite strengths in the study. And then let's also look at other variables in the study to see these were strengths. Okay, and specifically, as I said, for this point, you can, I didn't want the whole cell, just wanted this to be highlighted. You can exposure measures and covariates. Okay, so this is not just exposure measures, but outcome measures and covariates. Were they assessed in a way that was methodologically sound? Okay, now let's look at other covariates. If they talk about other covariates, how they were assessed. Nearly all the others were diagnosis related, and so we're almost sure that those were collected correctly. How do we know this? Because they use diagnosis codes, which I said are an accurate way of capturing diagnosis. So you could also point that out as additional strength beyond the Apache score. Because the Apache score and the diagnosis codes were captured appropriately, and that reduces misclassification bias. And also the outcome was captured appropriately here. So this is a strength. So this misclassification of strength, this is specifically for misclassification of covariates, reduced. Okay, so that's a strength. But you look at exposure, outcome, as well as covariates. In our case, we looked at the covariates that were assessed as well as the outcome. And so the outcome is also a strength because it was assessed using records. Okay, strength. Okay. Repeated exposure assessment. This point just brings up whether the exposure variable was measured consistently. This is more applicable to situations where your exposure variable is like a drug of interest, but not nurse practitioner addition. It doesn't really apply well. So, for example, was the exposure for each person measured more than once during the course of a study? Multiple measurements with the same result increase our confidence that the exposure status was correctly classified. A good example here, and I give example of high dietary intake, but you can think of smoking status. If your study was concerned with smoking as an exposure variable, then you want to make sure that you consistently, in the course of your core study, repeatedly measure smoking status. Because let's say someone was a smoker when you recruited them, and then 3 months later they stopped smoking for 3 months, and then they started smoking again for another month. So how would you classify this individual? So you would know that they were sort of, they were not completely a non-smoker or a smoker throughout the study. They were somewhere in between. But you wouldn't know that unless you repeatedly measured smoking status throughout the study. This is not applicable to our study, but I just want to bring up the point. Should you be looking at an article that has an exposure that's a drug or that's dietary intake or intake of something that you can point out to be, or even environmental exposure that you can point out to that this issue was repeatedly measured. Was there bias due to unadjusted confounding, right? So remember we talked about how the study used multiple logistic regression to adjust for confounding. And that's a positive thing. So whenever you see multiple regression, you point out to the fact that this allowed, let me make sure I point it out here. here that the study used multivariate logistic regression and that this allowed for adjustment of confounders. So first you look at, did they use any methodological approach to reduce bias due to confounding? In this case, we say they did, and therefore it's a strength. The other question you can ask yourself is, beyond these factors, is there anything else that you can point out that could have affected ICU mortality that's not accounted for? Absolutely. I think we raised the point of other extraneous factors that may not have been captured in the system that may lead to mortality. When I'm looking at these factors, I don't see substance abuse as a variable that's collected that could potentially also increase one's risk of ICU mortality, but it's not collected, and therefore someone could point out, well, it could be the substance abuse issues that could have led to the mortality outcomes. We also talked about in class the level of expertise of the persons who were trained, not the nurse practitioners, because we know that those were trained, but other practitioners. There were residents who cared for these patients, as you read the methodological approach. There were surgeons, so that's not accounted for. All that could have increased ICU mortality beyond the addition of nurse practitioners into the ICU team. So for this point, you could talk about both strengths and weaknesses, right? We talk about strengths because of the regression analysis. We can talk about weaknesses because of those extraneous factors not accounted for. Okay? Extraneous. Okay, so these are strengths and weaknesses. Okay. Blinded outcome assessment. Blinded outcome assessment happens when you, if the outcome assessment, basically the determination of whether the outcome has happened or not happened, is done in a blinded fashion. That's not stated in the study, and so it wasn't done. But there are certain studies where blinded outcome assessment does happen, and so no one is blinded to the exposure status of the patients. So this wasn't done here, right? So we don't know, we can't claim the advantages of blinded outcome assessment. Okay. So you could point that out as a weakness, that it wasn't done. Okay. If you would like to, this is much more appropriately looked at in the sense that, because you don't have to use blinded outcome assessment. You don't have to, right? But if you do, it's a good thing. So this is something you look for as a strength in a study. If it's done, then you point out as a strength. Okay. Number 12. So that's why I'm not putting strength or weakness here, right? Because it doesn't state that you have to do it. This is something that, if it's done, is a good thing, right? If it is a retrospective study, which it is, were there too many missing records for a particular variable? So how do we know that this is the case? A good clue is to look at the tables, because the tables sometimes have footnotes that tell you whether there was missing data for specific variables in the study. So when do you have too much missing data? So remember the point about dropout that we raised earlier, that directed us to this point, because dropout doesn't affect retrospective cohort studies. There's nobody to drop out of the study. However, there could be missing records. So this point is more applicable to retrospective cohort studies. And so we look at whether a particular variable has more than 30% missing. So for example, if values for CD4 count are missing, and CD4 count is a variable you collect in your study, then that means that 40% of the patients actually didn't have any CD4 count records. And if, imagine this is a variable that you're using in your study, either as a covariate to do adjustment or as an exposure variable, you can see how this can affect the accuracy of your results. Okay, and this usually happens due to bias in abstracting records or simply just missing data. It's not there. Bias in abstracting means the abstraction is done in such a way that may compromise certain records from being abstracted, but missing data just means the data isn't there. So the tables usually give us a clue, right? Looking at the tables, and this is where they would have a footnote somewhere here saying that we didn't have, there was missing data on this particular variable. And the total numbers always tell you especially where they give you, let me give you, this doesn't provide us with a good example, but what I'm trying to say is look at the footnotes. And if the footnotes say that particular variables had missing data, then you can determine how many were actually missing. For example, if they provided us with, let's say, a variable like smoking status, and they told us a number of smokers, but the number of smokers and number of non-smokers don't add up to the total number here, then you would be able to physically know how many actually had missing information. So that's another clue or way for you to give a number to how many records were missing. But in this case, we don't have a good example of that, but that's how you'd be able to find out that information. Turning back to our document, confounding by indication is point 13. This is somewhat of a challenging point to see, but it's more of a newer point, a point that has been raised in recent years. I said it's a newer point to raise. Confounding by indication is a specific term that's used to address a particular phenomenon that happens. At this stage, I would say that the easiest way for me to teach this is to give you an example, right? Confounding by indication usually happens in either retrospective cohort studies, and let me just stick with the retrospective cohort study example. So remember, retrospective cohort studies are done using data that exists, right? And when you're using data that exists, that is reflective of what is actually happening in a clinical setting. And so the confounding by indication problem occurs when a newer drug on the market is being compared to an older drug that has existed. And in some cases, and not in some cases, in most cases, the newer drug that is being compared to the older drug tends to look worse than it usually should be. So hold on to that point. So this happens when you're comparing newer drug on the market to older drug on the market, and the newer drug tends to look worse than it actually should be from a result standpoint. And like I said, I'll give you the example, but I just want you to hold on to that point. That's one way confounding by indication can happen. And the phenomenon was caught mostly in hypertension studies. And the example was retrospective cohort studies that were comparing beta blockers with diuretics. So diuretics have been around for years, right? And so when beta blockers came onto the market, people started finding very funny results from retrospective cohort studies. Essentially, beta blockers were actually being shown to people using beta blockers had higher risk of death compared to people who were taking diuretics. And that was counterintuitive, right? Because you thought, well, beta blockers are newer drugs, they have more coverage, the mechanism of action, it covers a lot more things. Why are these people from retrospective cohort studies being shown to have poorer outcomes? And this is actually the issue that was going on, which is why I said confounding by indication is specific to problems that have, not problems, but just the nature and the business of caring for patients in the clinic. So think about this. Who are given beta blockers typically? Beta blockers are prescribed by indication to individuals who have, it can have multiple indications, right? Not just for hypertension. So if the study is looking at a hypertension study where the goal is to reduce hypertension, right? Then people who are taking beta blockers may be taking it for other things. They may be taking it for angina, maybe taking it for other indications outside of just controlling hypertension, because that's why beta blockers are used, to address multiple issues. And so those people who are prescribed beta blockers tend to be actually sicker. And that's why the results turn out to be worse than actually is, right? Simply because of this confounding by, and the operating term here is indication. The indication of the newer drug is such that it essentially captures people who are sicker, and therefore whenever you're comparing it to the other drug, it shows that the newer drug has a negative impact on health outcomes. Not because the drug itself is bad or that the drug itself actually reduces, the drug itself increases the risk of poor outcomes, but just because of the fact that in a clinic setting, those drugs tend to be preferentially prescribed to individuals who tend to be sicker. So that's not the researcher's fault. It's just a function of how clinic works. So when you see confounding by indication, or if it is mentioned in a paper, that's what they're referring to. Okay. The other example is with statins, and where people would be preferentially prescribed Crestor because Crestor lowers your cholesterol, or it has a quicker reduction of cholesterol compared to the other statins, and so people comparing Crestor with Lipitor, Crestor tend to show poorer outcomes, but not because of the drug, but just because of the nature of prescribing. So that's confounding by indication in a nutshell. I just put it here so that if you saw it, you know what it was and would be able to explain it. If there was confounding, if there's the potential for confounding by indication, how would you describe it? So if you were comparing a newer drug to an older drug in a particular study, and you notice that the older drug tend to look worse, and in your clinical judgment, you might be able to say that this drug has multiple indications. And so because it's prescribed for multiple indications, it could be that those patients tend to be sicker, and therefore the results tend to be poorer. So you could point that out as a potential weakness if you do see it. In our study, it's not applicable because we were not looking at drug comparison. Okay, but if you picked a study where you were comparing drugs, this could be an issue that you could raise. Okay. Same thing, item 14 is related to item 13. Channeling bias. This also happens because physicians selectively prescribe newer treatments to sicker patients. Same issue brought up where now if you're picking a newer drug compared to an older drug, the newer drug looks worse. But just because the physicians are now saying, well, these are patients that could not be managed on these other conditions, so let's give them this new treatment in the hope that they're going to get better, right? So you may be comparing two antidepressants, but one is newer than the older one, right? But who's going to get the newer ones? The people who have failed the older treatments. And so preferentially people on the preferentially people who get the newer treatments are those who have failed older treatments, who are likely to be patients who have more severe depression. And so if you're looking at downstream outcomes of these two groups of patients, the group of patients that has been channeled to the newer drug tend to have poorer outcomes. Not because of the drug, but simply because of the patient population that is being served. That is channeling bias. Again, in our study, not applicable, right? It's not applicable to our study. So, in fact, I should just delete it there. It's not something we can quote as related to our study, but it is a weakness if you identify it in the study. Lastly, the global question. Beyond what is addressed in number 1 through 14, do you see anything in the study design, selection of participants, care setting selected, observation times, data collection methods, and measurement that either improved or minimized the study's ability to accurately estimate the effect of the exposure on the outcome? So I think we covered everything based on this point. We looked at everything. I think there's nothing else that I believe we missed. And so this is sort of a catch-all question. Is there anything else? Okay. And in looking at our study and all the areas, I don't think there's anything else that we could point to that could have potentially affected the exposure, the effect on the outcome. And so looking overall, remember, now you've done an assessment of the strengths and the weaknesses. The next thing is to make sure that you come up with a summary statement. Is this a fair, good, or poor study? Our initial look showed more strengths than weaknesses. Our review of our table here, okay, let's see, we had strength, strength, weakness, strength, strength in the study. We had a strength here. We had strength and a weakness. In other words, you could argue it either way, and the others were not applicable. So I think by and large, we have more strengths than weaknesses. And this is a study where you could either rate it fair or good, depending on your choice and how the points you decide to bring up. Okay, which 5 points you decide to bring up. Like I said, of the 5 points you bring up those that are major issues that you have covered during the initial review here, as well as the points brought up here. Okay, and identify the points that you want to bring up. You said you minimum of 5, but you can bring up more. I think looking at this, you could easily come up with at least 6 or 7 points to bring up. But overall, I believe you have more strengths than weaknesses, and so your design should your critique of the research design and the approach should be reflective of a study that's between fair and strong. I would classify this as a strong study for the most part because I think they try to, the major issue in terms of weakness would be the external validity, in my opinion. But again, I'm trying to help you develop a critical mind to come up with your own assessment. And so if you were able to justify this as a fair study, I would also give you credit for that because that is your own opinion, but also grounded in fact. And that will end how to do a second